Welcome everybody. Thank you for joining us today for our Alive Virtual Cafe conversations for September, nearly October, nearly end of daylight or start of daylight savings, which is really exciting. My name is Monica. I'm a research fellow with Alive, and I'll be co-chairing today with Professor Nikki Reevely, who is the co-lead of the prevention stream, who's also online, and we're, as always, supported here today by the Alive Hub. So Glenn and Caroline and Dana and Vicky. Thanks, Eileen. Oh, I'm sorry to hear that. I hope you're recovering okay. So before we get started, I'd just like to acknowledge the Wurundjeri people, who are the traditional custodians of the land on which the University of Melbourne is based. And I'd also like to pay my respects to elders, both past, present and emerging, of the Kulin Nation, and extend that respect to other Indigenous people present here today. So I'm joining you from Boon Wurrung land here in Melbourne, and I'd encourage you to pop the lands on which you're joining from. I'm sure we've got some diverse lands in the chat as well. I'd also like to recognise the lived experience within the room today and ask that we speak honourably and respectfully about ongoing emotional distress, experiences of trauma and mental ill health, and also the work of caring and experiences of care within this context. So it's my great pleasure to be chairing this session we'll have a presentation from Professor Darryl Maybery today, and it will be on hidden needs, holistic approaches to the implementation of whole person children and family models of care to support children of parents living with mental ill health. Thanks, Dana. And so the Prevention Across the Life course program of work within Alive is hosting this session today. So Darryl is within our program of work, and this is a program of work that is part of Alive, along with the Lived Experience Research Collective and also our Longer Healthier Lives in Priority Populations. Stream A around Aboriginal and Torres Strait Islander health, people's health, and also Stream B looking at unmet physical needs within people living with complex mental health needs. So as I mentioned before, we're hosting with Professor Nikki Reevely, and so our research program is really looking at thinking about reducing risks for poor mental health across the life course, improving access to preventive interventions both in primary care and community settings, and also thinking about capacity building. So thinking about how we can embed those interventions more deeply within those settings. Our other co-lead of our stream is also Professor George Patton. So please feel free as we go through the presentation today to pop any questions in the chat. We'll be looking out for that, and there'll also be some time at the end for some questions and discussion. So without further ado, I'd like to warmly welcome Professor Darryl Maybery. Thank you for presenting today, Darryl. Darryl is the Director of Research and Professor of Rural Mental Health in the School of Rural Health at Monash University, and has worked for 15 years as a mental health clinician and psychologist in the areas of drug and alcohol counselling, prison psychology, and employee assistance. Darryl's research contributions within Alive are very much using his expertise around rural mental health and resilience and the needs and impact of carers and family where a parent lives with mental ill health. Darryl is also interested in the translation of models of care that address intergenerational and life course issues to encourage a recovery and stigma focus. Thank you, Darryl. Over to you.
Thanks very much, and I'm really pleased to be presenting today. Before I do start though, I'm on the Gunai Kurno lands out here in Gippsland. I'll just share my screen. And first off, what a title. Perhaps a better title for the presentation is Hidden Children and an Opportunity for Prevention. Now, I say hidden children because that's really the research area that I came to some years ago. And what I want to talk today about is how I think we need to be thinking holistically, and we need to think about a family rather than a single person with mental health problems, or even carers and so forth. So instead of thinking one person, thinking multiple people. Now, I wanted to talk about the three key areas today. One is around the work that we've been doing in regards to parents, or my knowledge about parents in this area, around young people, and then around services and services associated with parents and young people. And early on, I'll give some background to prevalence and risk for young people who are brought up in a family with a parent with a mental health problem. But I first wanted to start with talking about why and how I got interested in this research topic. As I was introduced, I came to academia late. I was a clinician for 15 or 20 years. And I worked as a prison psychologist. I worked in drug and alcohol settings. And for me, working in those areas was a bit of a no-brainer, that stuff ran in families. You know, like I could name some families in a prison where I worked in Queensland that, you know, there were 3 generations of the family in jail or had been in jail. And so for me, that was how things were. Anyway, I started as an academic at La Trobe Uni in Wodonga, and as a level A academic in the early 2000s. And we ran a conference in the local community with the local anxiety support group around mental health issues, you know, an awareness raising thing, and we ran it at La Trobe. And the next week I got a call out of the blue of this lady who said, "Oh, look, I'm with the Supporting Kids group in Wangaratta, and I'd like to come and have a chat to you about, you do stuff with people in the local community and help them out. Could I come and have a chat?" Well, so we went and had a coffee downtown in Wodonga, and she said, "I wondered if you'd help our group with supporting us with research around the Supporting Kids group." And so we started talking about it. She started talking about parental mental illness and impacting on children. And I'm going, well, this is a no-brainer. But as an academic, a new academic, I went, oh, God, this is a whole new research area. And there's going to be thousands of papers on this. You know, this is such a no-brainer issue of trying to stop the cycle of illness in families that, you know, like I'm going to be spending weeks and weeks trying to come up with a literature review on this. So anyway, I went back to my desk. I think I found 8 papers. And there's very few studies that have ever been done on this in the early 2000s. And I really almost couldn't believe it. And so I then got involved with the Supporting Kids group, and we got a grant of some money. And, you know, that was the first paper I ever published in this topic area. But interestingly, we then went and we started we got a further grant with Vic Health and the Victorian government, and we started working along on an intervention with Rose Cuff from the Bouverie Centre. And we were sitting one day with Vic Health, and Vic Health said, "Well, how big's the problem?" And we all looked at each other and went, "What do you mean?" And I said, "Well, how big is the problem? You know, how many people are there?" And it really then dawned on me that the reason we were having trouble with convincing people that this was an important topic area and that these children really were hidden from sight was that there was a lot of people didn't believe us, that there were many people with a parent with a mental health problem. And so the first thing that we did was went back and look at prevalence and prevalence and risk, and published a number of papers around prevalence and risk. I'll talk a little bit more though in terms of the parent area, then around parent-focused interventions that I know about in this area, and I'll do a little bit on what practices are important. I'll follow then on what you should do for children and what workforce should do.
Darryl, could I interrupt you for one moment?
Yep.
I'm not sure that your slides are advancing. Is that happening for you, Dana, as well?
Yes, I was just going to ask if you could be full screen as well, and we're still on slide 1 at the moment.
Okay, how's that?
There we go.
There we go. We're on slide 5.
Thank you.
Thank you.
Okay, cool. Okay, so that's much better for me too. All the people are not on a second screen. Anyway, so the first series of studies in relation to prevalence that we did, we took what data there was in Australia around families, how many families and how many people with mental illness. And I know this is rough and dirty, but we then combined the two together and we came up with this figure of 23% of the Australian population have a parent with a mental illness in their family. And that works out to be about 1 million children. So this is early 2000s, mind you. At the same time, I went to the Victorian government and I asked them in adult mental health services how many of their people in adult mental health services were parents, and we came up with 20% of those. But I'll talk a little bit more about this in a moment. We also ran a community-wide study of about 300 people, I think it was, or 500 people. And anyway, 14% of those parents self-identified as having a mental health problem. And you can see the numbers over this other side of how many children that represents. In more recent times, we've undertaken a review of the literature in terms of how many parents are attending adult psychiatric services. And in that review, we reviewed 9 papers, and those papers said between 12 and 45% of all patients attending adult psychiatric services were parents. But the middle range of that was between 36 and 38% of parents. So that's how many parents we think in psychiatric services have children or are parents. So that was the angle of how many parents in adult services. But then we thought, well, okay, in child and adolescent mental health services, how many of those children have parents with a mental health problem? So Tim, a PhD student of ours, he undertook a review of the CAMS literature, and he found 18 studies, and he found the prevalence of CAMS children with a parent with a mental illness range from 16 to 79%. But the most comprehensive study was done by a Dutch group who found that 36% of mothers and 33% of fathers of children attending CAMS also have a parental mental health problem. So prevalence, you can see, is around the 20 to 30% mark, depending on what you're wanting to measure. So in the general community, it's 20 to 25%, basically. And in the institutions, it's a little bit higher rate than that. Now, in terms of risk to children of having a parent with a mental health problem, of course, the Nordic countries, they do data collection and data linkage a whole lot better than anybody else. And a Swedish study from children who were born in 73 to 78 with a parent with a mental health problem or with a parent with a substance abuse problem who were now 30 to 35 years of age showed mortality much higher, specialist psychiatric care much higher, substance abuse problems themselves much higher, and so forth. So the risks are great. About the fifth last slide, I'm going to try and bring all this back to the roadmap for people who are familiar with the roadmap. But this next study that I wanted to talk about is from Western Australia, and it did a similar thing of linking data of parent hospitalisations with what are the outcomes for really young children of those parents. So these parents were hospitalised, 1,000 parents hospitalised in 2009, who had children born 5.5 years earlier. And it was shown really clearly that, and based on school readiness data, so when a child goes to school, there's a school readiness questionnaire filled out. So these people access the school readiness questionnaire, and they basically show that one short hospitalisation of the parent has a major impact upon school readiness. So think of the roadmap in terms of schools and school readiness. Now, in terms of what do you do about it for parents, or what are the programs out there for parents? There was a meta-analysis done 10 years ago of the interventions for parents. And those interventions showed that the risk of developing the same mental illness as the parent was decreased by about 40%. And by the way, that's about the rate of more likely having a mental illness the child is themselves. Two of those interventions in the review were one called Let's Talk About Children, and another one, Family Focus, Family Talk. Now, Let's Talk About Children, we brought this to Australia and implemented it around 5 or 8 years ago and evaluated it. It's basically where what you try and do is get the adult mental health clinician in adult services to have a discussion with the parent about their parenting, their circumstance and their children. And really it does a strengths and vulnerabilities on the children, and it's a strength-based approach with the parent, working closely with the parent. There's Emerging Minds have a training program on Let's Talk if you're interested. Others, there's many other approaches now around. Brendan from the Bouverie Centre have been working on developing a single session approach. There's another, Adrian Falcol from New South Wales has developed a thing called the family model that some psych services follow. And the family talk is a US model of the whole family being involved, and that's by William Beardsley. So what should you be doing with a parent? It's really about being strength-based, as I said, and being in a partnership with the parent to help them around their parent. So the sort of things you might do with a parent is help explore what their attitude is around talking to their children about their mental illness. Often it's not talked about in a family. And help unpack that and develop and support strategies for talking about the illness with the children. Two things that we think of with children, of what a big part of the issue is, that if you don't talk to children about it and children don't understand what's going on in their family, often they think they're the cause of the mental health problem in the parent. And also, the flip side of that is that often they think they have to do something about it. They have to fix the problem of the parent. And neither of those things are true. They may help and be involved and so forth, but we think a key thing is overcoming those two things of not feeling responsible and not feeling responsible to do anything about it necessarily. So also thinking about what's the parent's explanatory model for their mental illness and what is their understanding of their own mental illness. The thing that amazes me about doing research in this area, we're thinking about what does the child know, what does the child know. Often the parent doesn't have a really good understanding of their circumstance and issues and so forth. And so helping them better understand that. And I'll talk about psychoeducation in a moment in terms of services. But also helping the parent to reflect on the child's experience of the parent's illness, so what symptoms, feelings and events have they experienced? What do they think their children have noticed? And so forth, and how do the children make sense of that? So again, getting that, am I responsible for this? Am I causing dad to be like this or mum to be like this? Anyway, so that's the parents. I now wanted to talk a little bit about the children and young people and what are the issues for young people. But what are the interventions that are around as well, and what should the content of an intervention? I'll talk a little bit about an intervention that we've developed and implemented. But the issues, as I said, the issues for young people are around, their responsibility in the matter, but also things like in the UK, they talk about young carers and having carer responsibility and parentification of young people. But certainly stigma and shame is another big one that often don't ask for help. As I said, lack of knowledge about mental illness and vulnerability. And often the families are isolated and alone. And a key thing I think of is that you need to be helping young people to make other connections with other people. It amazes me that I talk about the negative, and that's all I've talked about today, but some of the people I work with, the lived experience people, had families. They're some of the strongest, most resilient people that I know. And generally, if that's the case, there's been some other person who's been in their life who's been a rock for them in some way and a real help for them. So that's where we see expanding connections to other family members, but to outside the family is really, really important as well, we think. In terms of interventions, there should be age and stage of development appropriate, of course. Mother-baby groups I know nothing about, and I know nothing about the groups, and there's lots and lots of work being done in this area, postnatal depression and so forth. But certainly the early work we did with Ruth Rose Cuff, who's now with the Satellite Foundation, on peer support for children, younger children. There's sorts of things like school and after school and school holiday programs, and they're psychoeducation and peer support focused, but they're also about building self-esteem and developing coping strategies and so forth. And also similar at an older age group, the 13 to 18-year-olds. But in terms of the older age groups, we targeted with an intervention that we started developing about 6 or 8 years ago, a thing called MySpot, of the 18 to 25-year age group, basically emerging adults. Now, what's MySpot? Well, it's a supportive, preventive, online and targeted intervention. And again, I want to bring this back to the roadmap a little bit later on about the rural and remote aspect of the roadmap. So we started thinking about, well, an online intervention is the way to go. Now, we developed it over, starting with the evaluation we did back early on with Rose Cuff, but then looked at what are the ingredients in effective supports, what do young people actually want, and how and what do youth want from an online intervention. So in terms of online, what's the important characteristics? Now, MySpot's 6 online 1 hour facilitated weekly chat sessions where the young people are anonymous. So they have avatar names. They're not anonymous to us, but they are to each other. They also have a private online diary. We call it a My Thoughts Spot diary. But it's opportunities for the young adults to chat informally with each other, but in a facilitated group. We haven't run these for a couple of years now because of finance, basically. But we ran them with postgraduate students being the trained facilitators at Monash in Ed and Dev Psych students at Monash. There's also opportunities for one-to-one private chat sessions and phone sessions. And there's a whole lot of resources and videos and so forth on the weekly topics. And there's weekly mood monitoring as well. The sessions are welcome and orientation, the first session. The second is really about psychoeducation, about mental health and mental illness. but then it's more personalised and around me, my parent, and my relationships. And then managing stress, then caring for yourself and others. And, am I caring too much? And then basically pulling it all together, the last one of those. Now, we found good support for the pre-post follow-up support for the intervention. So that's parents and children around information, but a lot more of my work more recently has moved towards service providers and what can services actually do. Certainly I want to give some talk about carers and family and what are the fundamental things that an organisation should do. But a few things around knowledge, skills and confidence in service providers. We've probably, I've developed a measure in this area, and with a whole lot of international collaborators who moved it, to their languages and stuff. But the key things are around skill and knowledge about parenting and children. So a clinician often finds, particularly adult clinicians, and this is my own personal experience of working with prisoners and drug and alcohol, is that I know a lot about adults, but I don't know anything about children. And so having an adult clinician having to work about parenting and children can be sometimes really difficult for them. Referral and collaboration with other services is really, really important as well. But at the end of the day, what we've found in most of our research that comes up as a key variable is the clinician being confident to actually do the work with parents and children. What I do want to talk about, though, is my research moved from just families to actually taking in carers as well. And I think this applies to carers. I don't consider me an expert researcher in the area of carers, but I think what I'm going to talk about now has implications for both carers and family equally. I won't go into the detail of the numbers and so forth. We all know that caring is such an important and from a whole range of financial but emotional, all that sort of stuff. Anyway, so how should mental health services engage with carers and family? I started really thinking about this 4 or 5 years ago, and policies everywhere say that there should be a close relationship between carers and family and the health service and mental health services. Guidelines, UK, the US, Norway, World Health Authority, Australia, there's multiple documents that say that's really, really important to have a close working relationship between carers and family and health services, because they benefit the mental health service user, they benefit the carer, and they benefit the family members. But in reality, what happens? Well, a classic study back in the early 2000s said that psychoeducation is conducted in only about 1/5 of all hospitalised patients with schizophrenia, and only for one family member in every 50 patients. So that means that 2% of carers and family members receive psychoeducation. And I don't think that's much changed in many years. So anyway, so I then started to go, well, okay, well, what are the fundamental things that services should do to engage with carers and families? So what practices are fundamental to engagement? So anyway, so I went off and I looked at past questionnaires, and luckily there's a good study's been done on 32 carer measures by Lynn, and we looked through those and found that 12 of those were somewhat relevant to relationships with carers and engagement. There's the Australian Carers Experience Survey, and it has nothing about young people or young carers on it. You've got to be over 18 to fill it out, for example. our own workforce questionnaire, which is not filled out by carers but by workers. So we looked at those for what are the subscale structure or the factors within them that are related to engagement between services and carers and family. We also went looking at research practice standards, and we'd undertaken with Kim Foster a major review of the literature around child and adult services of how they should engage. But we also looked at practice audit tools as well. So tools that audit around family-focused practice. We came up with 7 fundamental ways that mental health services should engage with carers and family. So number 1, they should identify and acknowledge family and carers. Now you might go, that's pretty friggin' obvious, but in terms of family, that ain't so obvious. In the early days where we were looking at prevalence, the Victorian stats people said to us, hey, lucky you came to us, because some other states don't actually record whether there's children in an adult's who comes to adult services or not. Now that's changed considerably now, but identifying and acknowledging is the first step. The second is engage and communicate with family and carers. The third is involve family and carers in planning and collaboration regarding the service user. The fourth is assessment of the family member or carer's needs. The fifth is provide or offer ongoing support to family and carers. The sixth is provide psychoeducation to family and carers. And the last one is to provide or recommend referrals to family and carers. So anyway, that's what the literature says. But so where does lived experience fit with all that? What do they actually think? Now, a lot of that literature is based on lived experience. And so, but anyway, what we decided to do is we decided to develop an online anonymous mixed method survey. And we basically opened it up. We didn't go through carer organisations. We didn't go through anything like that at all. We basically went via Facebook and advertised the local community. We got 134 family members and carers, around half and half each. Now, who they were caring for, a small amount for a spouse partner, a lot for a parent, and some for sons and daughters. Now, we didn't tell them anything about what the study was about, other than it was about, engaging with services, and we wanted to know what their opinions were. The first questions we asked were open text questions. So we said, what have you as a carer family member received from mental health services? And the second question was, what would you have liked to have received from mental health services? So just basically open text questions. I think we asked them to give 3 things that you received and 3 things that you wanted to receive. So anyway, to the first question, we got 249 responses. And to the second of what they would have liked to receive, 223 responses. We then took that data, and as you can see down the left-hand side, we did a deductive analysis. So we didn't actually thematically analyse it. We took the 7 core factors down the left-hand side. You can see 1, 2, 3, 4, 5, and there's 6 or 7 on the next slide, and went through and said, what did you get? What did you want? And classified them independently to us. Anyway, so we got things like, for the first fundamental theme, acknowledge and welcome me to the ward is what they received. Other people said it would have been good if they'd been more inclusive of family members and their information and opinions. Would have been good if they included us as their patient in the health planning of the service user. It would have been good to look after me. No one seemed to care about how my mother's illness was impacting upon me, especially when I was a child. For the 6th and 7th, so more education and communication about the condition and how to care for her would have been good. So basically we found that the carers and family agreed with us about the 7 fundamental things, and there were a number of others, as well that we did thematically analyse. And they didn't add on they added on new information, but not actually new ways of engaging with carers and family. In the online survey, so they were the two first open questions we asked, so they had no idea about what our 7 were, but then we actually moved them onto a page, and we said, well, okay, these 7 items, we got people to rate them on a scale of 0 to 100 of how important they were. So the first question, how important is it for health services to identify and acknowledge carers and family of the patient? And so our 132 people rated those. So they rated them all very high. They all said these are all important. So we think that these 7 are fundamental to what mental health services should do. Interestingly, we then, the ratings that they'd given on those 7, we did a factor analysis on that, and we came up with 2 core factors that are being measured by the 7 fundamental things. 4 of them actually load out as being of benefit to the service user, and 4 of them load out as being benefit to the carer or family member, with one item going both ways. So I think that really is really interesting as well, about the engagement with carers and family has double benefit, and clearly it suggests double benefit to both the service user and the carer or family member. So that's the 3 areas, and my time is pretty soon coming to an end. But another group that I'm involved with is an international research collaboration, and we meet every 2 years apart from COVID, and we've been meeting for 10 years now. And just recently, and we're all work in the area of family and parental mental illness, and we recently published an editorial perspective, or what we think is our roadmap in terms of parental mental illness. And I just wanted to finish off by going through a couple of the recommendations or the principles that group have indicated for where parents and children are involved. So you should be bi-directional in the relationship between the parents and children's mental health. Both need to be addressed. So it's a 2-way back and forth stream. Should be working towards supporting children's mental, emotional and social needs as soon as you possibly can, as early as you possibly can. And that Western Australian study that I talked about before really links to that. Supporting parents plays a critical role in the children's development. You should be collaborative and strength-based in your response, and it should be culturally sensitive as well, and to the family configuration as well. Children and other significant family members need to be considered in ongoing conversations and decision-making opportunities with services. That's what I've talked about in the fundamentals just previously. All health services, community-based agencies have a role in addressing the needs of children and parents. And again, talk a little bit about that in terms of the roadmap with schools in a moment. There's many opportunities to do something. So in terms of the Alive roadmap, I pulled out the dot points from 5 dot points from that. The lived experience, well, it speaks for itself of the way forward with that. But education and professionals, I think the 7 fundamentals are a fairly clear direction on that. Prevention in schools. Where are children and families in our approach? You know, the Western Australian school readiness study says that there should be something around, children from parents with a mental health problem as they're starting school. Legal rights, I'm not too sure. I know a PhD student working on this area. And rural and remote mental health, I wanted to just focus on this for one moment as well. I work in a school of rural health, and I'm a rural background person myself that have benefited from being able to access education in particular. But I wanted to talk a little bit about access to finish off. When we were developing the MySpot program, we were developing it on basically face-to-face style programs and moving that to being online. But I thought it was quite important to go back and go, well, okay, there's the FAPMI strategy. I don't know about whether people know about that in Victoria, that it's basically been around for 20 years, around trying to do stuff in the area of family mental illness. And peer support programs have been strongly pushed in Victoria, probably here more than anywhere in the world, I would say, knowing my international colleagues. But so what we did, we thought, well, okay, we'll go find all of those people who run peer support programs for face-to-face parental mental illness programs. And we asked them back in 2016 what was offered during the year. We also asked about how ready the sector is for online supports. But in terms of what was offered in terms of peer support programs face-to-face, there were 28 programs and there were 183 young people, that's an estimate, that were involved in those programs. But keep in mind, we were talking to the people who were running the programs, and they run the programs and knew how many people were in them. 83% of all the face-to-face peer support programs were delivered in urban areas. And so they were also basically highly supportive of online. So here we're talking about 183 young people, okay? Can we go back to my original estimate of parental mental illness in Australia? You know what I mean? Like 183 people in peer support programs. Like it's crazy ridiculous that we have to do something to increase access to people. I'll get off my soapbox now about that. To finish up, I just wanted to, there's a whole lot of people, researchers, family members, carers, service users over time that have been involved with stuff. But I particularly wanted to acknowledge Andrea Roper, because the MySpot program was really her baby. And she also happens to be a lovely mother of my two babies as well.